Hello, I'm Howard Lim. I'm a medical oncologist at BC Cancer Vancouver. And today I'm going to talk about evolving therapeutic approaches in advanced unresectable biliary tract cancers. There's a published review paper created by several of my colleagues as looking at the emergent systemic therapies in advanced unresectable biliary tract cancers, and it's been published in Current Oncology as well. So biliary tract cancers is a group of rare aggressive malignancies that lack really effective treatment options. For the most part, we've really only had chemotherapy for the last decade. But more recently, there is a novel therapies that are demonstrating promising results in clinical trials. And this is the addition of immunotherapy, as well as biomarker-driven targeted therapy. These new therapies are starting to change the current treatment approach to biliary tract cancers. So biliary tract cancers compose of a number of subsets. So we have the intrahepatic cholangiocarcinomas, extrahepatic cholangiocarcinomas, as well as gallbladder cancers. So they are a bit lumped in all together. And for the most part, it is first-line chemotherapy is cisplatin gemcitabine. There is evolving therapy with gemcitabine, cisplatin, nab-paclitaxel. There's subsequent lines of chemotherapy with either 5-FU oxaliplatin or liposomal irinotecan 5-FU. There's evolving treatment with immunotherapy, which I will discuss in a second, as well as a number of biomarker-driven drugs as well. So this is really looking at FGFR fusion rearrangements, for which there are a number of targeted agents for this. Two are Health Canada approved. The other is looking at the IDH1, IDH2 mutations, and this happens in about 10 to 20% of cholangiocarcinoma cases, for which subsequent line therapies is ivosidenib. There's also looking at NTRK fusions, for which there can be the NTRK fusion inhibitors with larotrectinib or entrectinib. There's also BRAF 600E, which is dabrafenib and trametinib, target this variant, as well as HER2 amplification and overexpression. And the subsequent line therapies would be looking at trastuzumab, pertuzumab, or else trastuzumab deruxtecan. And for the most part, most of these biomarker-driven drugs and testing are currently not routinely funded and done in most patients. Mainly, most of these drugs have not been approved for funding. So if we take a step back and look at really chemotherapy for cholangiocarcinoma, the mainstay is cisplatin gemcitabine. There has been now reports out from the phase 3 trial for GI ASCO just in January that the trial of gemcitabine cisplatin nab-paclitaxel versus gemcitabine cisplatin unfortunately was negative, and that so therefore cisplatin gemcitabine is still the main backbone for chemotherapy. And we are still looking at the subsequent lines of 5-FU oxaliplatin. In terms of liposomal irinotecan and 5-FU, that's not routinely funded, and it's really phase 2 data. And there are places that will use more irinotecan and 5-FU, especially in patients who have ongoing neuropathy issues from the cisplatin first line, may not be able to have oxaliplatin in the second line. So there is evolving now treatment with immunotherapy. So durvalumab with gemcitabine and cisplatin has been positive in a phase 3 trial, showing around a 2-month survival benefit over cisplatin gemcitabine alone. This is now Health Canada approved, as well as recommended by CADTH, and is now going through the various provinces about funding. And this is available through a compassionate access program through the pharmaceutical company currently, and hopefully we can have this available to all Canadians by the end of the year. There's also a press release of pembrolizumab with cisplatin gemcitabine-based chemotherapy, showing it's a positive phase 3 trial, but the data is yet to be reviewed and released. There is emerging phase 2 data about pembrolizumab with lenvatinib and nivolumab, but again, this is still early phase data. So with the more recent phase 3 data, immunotherapy at least has become more established with chemotherapy, but the subsequent lines will need to be established with further trials. So current first-line systemic therapies really have started to evolve with positive results from TOPAZ-1, which really is the first positive trial we've had since cisplatin gemcitabine almost over a decade ago. And there's a positive recommendation from CADTH with respect to funding with this. There are some now biomarker-driven therapies which are approved for Health Canada for second-line therapy, but most patients within Canada face challenges around access. Number one, because these are not funded or recommended by PCODER right now. And this is really due to a lack of phase 3 data. Now, it's difficult to generate phase 3 data for these patients because it's a very small subset of already a very rare cancer. And because the drugs aren't funded, there is a difficulty about getting biomarker testing. And this varies from province to province, as since the drug is not available for patients, some provinces aren't funding the biomarker testing. The biomarker testing may be available to patients, but depending on which biomarker, it might be only on an individual basis. So there could be difficulties with respect to tissue, as tissue is limited in biliary tract cancers because it's hard to biopsy. And if you're sending off a sample, one for a HER2 test, and then you have to send off a sample for NTRK testing, and then sample off for IDH1 testing, depending on the company, in some cases, patients have to choose which biomarker test depending on the pharmaceutical company funding, and that can be complicated. And also, most of these patients are very sick, and so to become eligible for second-line therapy and beyond is a very small portion. So still, while we are making progress, there are still a high unmet need for more effective therapies, especially in the first-line therapy. So it will be interesting to see what that phase 3 data with pembrolizumab with cisplatin and gemcitabine will be, and how will we decide between pembrolizumab or durvalumab. So again, really looking at Canada, it's great to see that we're moving forward, at least with immunotherapy in combination with chemotherapy. And that's really exciting for our patients. It really doesn't add much toxicity to the treatment, and hopefully allows patients better outcomes. And hopefully with better systemic therapy, this allows more patients to be at least eligible for second-line treatments. Where we struggle in Canada still is that access to targeted therapies. While some of them are Health Canada approved, it's not funded, and largely because of the data from phase 2 trials, where there's a lack of a comparator arm. From the P-coder aspect, they can't do really a health economic analysis because there's not a comparator arm. So is there a mechanism where we could use real-world data for that comparator arm to help with that economic analysis to see if we can move things forward? As a phase 3 study in this population may be quite difficult. Having said that, it is exciting to see that there are more novel agents coming through the pipeline. Unfortunately, there is a disparity, as it is still a user pay option. And in some cases, the options aren't available in Canada. The IDH1 inhibitor, ivosidenib, is only available in the US at a cost of $30,000 US. Most of the other drugs, again, are user pay. So even trastuzumab deruxtecan for HER2 positive would be a user pay out of pocket. Same with pemigatinib, the FGFR fusions, or even looking at BRAF inhibitors. Now, the pharmaceutical companies do try to provide compassionate access and discounts, but again, it's not an ideal situation when we're trying to look at a universal healthcare system within Canada. But hopefully, as we're able to evolve and have more data, maybe we can convince the payers to then begin funding for these drugs and gain access as well. And once we have access to the drugs, that might at least help us convince the system to begin paying for the testing and to put all the testings in a unified sort of panel so that the tissue isn't used up by sending it to several different companies for individualized testing as well. So hopefully there can be some efficiencies and cost savings there. So with that, thank you very much for your time.